A moment of silence that I should exploit to continue the evening. So as you all know, my name is Andrew Perry and I'm the moderator for tonight. Joining us on stage are a number of other distinguished guests. I'd like to quickly run through the biographies of each of these and then the panel session will begin. So on my right, your left, starting at the end, we have Professor Justin Beilby, who is the Executive Dean of the Faculty of Health Sciences of the University of Adelaide. He graduated in 1981 and subsequently worked in general practice in urban and rural settings from 1986 until 1997. He then entered the University of Adelaide as a senior lecturer in general practice and subsequently became the Professor and Head of the Department of General Practice in 2002 until 2005, when he moved to take up the role of Executive Dean. As Executive Dean, he oversees all undergraduate training in medicine, nursing, dentistry, health sciences, psychology and public health at the University of Adelaide and is still a practising clinician. You've already met Minister Snelling. Next to Minister Snelling is Dr Sophie Plagakis, and they're obviously not listed in order here, hence me flicking through these notes. Dr Plagakis is a urology registrar at the Flinders Medical Centre, and as a medical student at the University of Adelaide she held positions within the University Council and the Adelaide University Union, and she graduated with her MBBS in 2009. As a junior doctor she chaired the then South Australian Institute for Medical Education and Training, now the South Australian Medical Education and Training Organisation, and she chaired the Junior Medical Officer Forum in both 2010 and 11 and was a South Australian representative to the Australasian equivalent of that body. She's currently completing a Masters of Public Health, but not through Adelaide University, through Monash University. Outside work, Dr Plagakis has an interest in health economics and health policy, is fluent in English, Greek and French languages, please don't use any of them tonight other than English, and has a particular affinity for Disneyland. To our left, we have Dr Patricia Montanaro. Dr Patricia Montanaro is the President of the Australian Medical Association South Australia and is the 114th person to take on that role. Dr Montanaro is a general practitioner and has been a doctor for over 25 years. The first half of this time was spent in a wide variety of roles, from time spent in hospital through to time subsequently training in the specialty of general practice. During this time she's worked in both private and public settings in both the hospitals and in the community. She's also worked in a number of non-clinical roles with a strong focus on health outcomes, advocacy and having an interest in bringing about social change. And through this has been on a number of boards including QUIT, the college, that being the Royal Australasian College of General Practitioners, and the AMSS board. Subsequent to Dr Montanaro we have Mr Rob Lucas, and so you've already received an introduction for him, and our final member of the panel tonight is Dr Peter Rischbeith. Dr Peter Rischbeith is a former president of the Rural Doctors Association of South Australia and is a rural doctor in Murray Bridge, having been a partner of the Bridge Clinic for the last 26 years. I've taken a number of referrals from Peter during that time. Peter is a GP obstetrician and anaesthetist, and he and his partners provide comprehensive medical care to the community of Murray Bridge. He was the president of the Rural Doctors Association of Australia, that's of Australia, not South Australia, in 2007-2008, and prior to this the Rural Doctors Association of South Australia president. He currently is the RDSA Vice President Industrial and is a clinical need for NETA, a member of the ASA State Council and a member of the SA Clinical Network in neonatal and maternity services. Peter's been actively involved in the teaching of medical students, intern and registrars, and has been providing work experience for prospective medical students for many years. With that, I'd like to bring the panel to a opening. Now, in terms of the format for tonight, there are a number of rules and I will quickly run through them. I will pose the first question to initiate the panel discussion. All of the panel members have been made aware of what that question will be. I'll subsequently facilitate the discussion by taking questions both from the floor, and we have at least two people, I can see one person there and a second at the back, who will take questions if you have them. Another way to pose questions to the panel members is via our hotline, which is listed up here, and we've already had a number of questions sent through. I think the majority by Dr Rischbeith, but that's okay. If you have a question, please put your hand up and we will take those questions where possible. I would ask that if an interesting line of discussion is taking place, that you do keep questions to that particular topic, but obviously we've got approximately 45 minutes tonight and we've got these esteemed guests, so it would be nice to cover a number of topics. So without further ado, I'll move on to the first question for tonight's panel, and that question is: there has been occasional talk of a third medical school in South Australia. What is your position on this notion? And I think the appropriate person to begin our discussion on this would be the Executive Dean of the University of Adelaide, Professor Beilby.
So thank you very much, and thank you, Andrew.
Is it on? There we go.
Thank you very much, Andrew. A number of years ago, about 6 or 7 years ago, both deans of medical schools got together and started planning for the right workforce for South Australia. And that includes just having 2 medical schools, quite clearly. We can't actually at the moment adequately train our graduates when they leave the training pathways, and the biggest issue aside from interns is actually the career pathways post-interns. The state is actually functioning very well with 2 medical schools, and the biggest priority now is actually the maldistribution and the career pathways post-interns. And putting that package together is really the next priority, not a 3rd medical school.
Right, would anyone else like to comment on that? Mr Snelling, is that part of the SA government's health workforce planning?
Well, look, I think I'd agree with Justin. I'd need a lot of convincing for the need for a 3rd medical school. My memory serves me correctly, Western Australia only has 1. South Australia has 2. I'd need a lot of convincing before agreeing to a 3rd, and I agree with Justin. One of the significant issues we have is making sure that we can provide adequate training places for those doctors. I think a 3rd medical school with an associated increase in graduates would be a little bit difficult for us to accommodate them all.
Minister Lucas, anything? Oh, sorry, Shadow Health Minister. No? All right. Dr Rischbeith.
Hello there. I think there's a challenge already. Can you hear me? I mean, there's already a challenge in providing adequate training for the undergraduates in the 2 universities we've got already. 87% of rural practices are training GP, registrars, RMOs, interns and medical students. So another medical school would provide huge challenges, would dilute the capacity of those supervisors already in place doing the teaching and training. So yes, maybe 10 years ago we were short of medical graduates. That might have been a good idea, but I think we've got to concentrate on making sure that the current undergraduates get quality training, get enough exposure to patients, and if we get that right, then we'll get the standards up to a level where then they have this next challenge of what's going to be their career pathway, and that will provide headaches for all of us in the next 20 years, I believe.
Look, I'll go one step further than Jack and say I don't support it.
The AMA would concur. We do not believe that we need a 3rd medical school. I'm sure that this group is well aware that in 2004 there were 1,287 interns, 2012 3,100, and 2016 3,970. What we need is assurance of intern trainship, we need assurance of where the training pipeline will lead, and we are talking about 1 to 2 years of general training and then 3 to 8 years of specific training. What we need to find out is how we're going to utilise the health workforce we already have and address the maldistribution issues. We are going to have to look at how we do this training, private hospitals, community settings, private practice. Medicine has changed, the delivery of healthcare has changed, the training of medical students need to change, the training of trained doctors into their specialty training too.
Thank you. Any comments?
Yeah, I just wanted to echo what Dr Rischbeith said about how we just don't have the capacity within the healthcare system to continue training extra people from a hospital point of view. I mean, we've often got 5, 6 medical students on a ward round and maybe 2 patients, depending on what sort of unit you're on. I was just wondering, considering how many medical students we have in the audience today, how many of you feel that your clinical training and your clinical years and your exposure through ward rounds in the hospital setting is adequate by the time you've graduated? Do you all feel that by the time you've gone through 6th year, you have seen everything you need to see and you're confident that that exposure was actually worthwhile and quality?
So Dr Plagakis is doing an audience poll here, old-fashioned way, I think.
Any hands up? No. I think
right.
that sort of says it all.
Okay, I think we're going to take it to the people now. There's already been a number of questions that have come through via the text line, but if there's anyone who feels brave enough or irate enough that they want to put up their hand and put a face to the question, then please do so.
Thank you very much. Do I need to stand up?
Please make sure you identify yourself as well.
Sorry, I've just written it down. It's a long-winded question. I apologise for that.
Oh.
My name is Matt. I'm one of the surgical registrars from the Royal Adelaide Hospital. This question is more directed towards the ministers here. Good evening, ministers. Thank you very much for coming along. So, ministers, I would like to ask how you intend to attract and retain quality doctors in South Australia, given that on average doctors' wages in South Australia are 10% less than doctors in the rest of Australia. This is especially pertinent given that South Australian doctors have not seen a pay rise in the last 2 years due to, Minister Snelling, your department stalling with the enterprise bargaining agreement. How would you respond to that, ministers?
All right.
I can assure you it's not my department stalling on the enterprise bargaining agreement. We're as keen to get it resolved as anyone. The department, obviously in any enterprise bargaining process, the employer will have issues that they want resolved, as well as the employee will have issues they want, employees will have issues they want resolved. The government's been trying to negotiate with SASMOA for more flexible rostering arrangements for senior clinicians, senior consultants. As I move around hospitals, one of the biggest issues presented to me and that I hear about is junior clinicians not having the senior support that they need, particularly after hours. We also see issues in our emergency departments with delays, with call-outs having to be arranged to get diagnoses. So particularly in radiology, as well making our acute medical units work more effectively by having senior clinicians available after hours. We have put to SASMOA a very, very modest proposal to try and have more flexible arrangements. Now, and SASMOA up until recently have been or directly opposed those changes. I had a meeting with the President of SASMOA, Dr David Pope, and I think through that process we've been able to resolve that particular issue. I think we'll get it resolved to both the satisfaction of the union and to the satisfaction of the government, provide better support for junior doctors in our public hospitals on weekends and after hours, as well as providing a far more efficient health service where, particularly diagnoses, it's those sort of diagnostic areas like radiology, we can have senior clinicians available in the hospital rather than having to do delayed and costly call-outs. So I hope to have this issue resolved quickly, but I can assure you that the government's as keen as anyone, as keen as you are, to have this issue resolved. On the question of the remuneration of doctors, I don't agree with you. I do think, particularly our senior clinicians in South Australia, are remunerated as generously as anywhere else in the country.
Can I ask a follow-up to that question, or wait till Mr.
No, we're going to have to keep the questions moving. So thanks, Dr. Hauser. Mr. Lucas, would you like to comment to that?
Well, on this particular issue, I have the great advantage of being able to snipe from the cheap seats because I'm not engaged in the actual discussions. I've had experience in negotiating as former Minister for Education, as Treasurer with public sector unions and associations, and the first thing I realise is that they're never as simple as either side seeks to portray. And I say that frankly, either the government or the public sector union or association. I accept that they're always much more complicated. I do accept in relation to this, having had discussions with SASMOA, that it just does seem extraordinary that this has been 3 years in the making, but as I said, and certainly the AEU, or say as it was before then, would never have accepted that set of arrangements, I can assure you, as a former Minister for Education. But I accept there are cultural differences between the doctors and the teachers in relation to the way they conduct their industrial negotiations, and for that I guess the health system should be grateful. Bottom line is it'd be easy for me to say, hey, we'll promise the world from opposition and deliver nothing when we're in government. The reality is I don't know the detail of your negotiations. I don't know what the impact of various claims will be on the budget, and we'll reserve a judgment until we see it. We hope, I can only join with Jack in one respect, although we're coming from a different perspective, I certainly hope it's resolved before March 2014.
All right. We might move to now a question that's come in via the text line, and this question is, how is centralising our whole healthcare system benefiting the community? It means smaller hospitals have less resources to treat patients in their local areas, and it means greater delays in accessing definitive care and greater risk for patients. What policy will you, and I presume that means the Minister and Shadow Minister, be taking to the March 2014 election to ensure this is addressed and regional communities in particular do not miss out? I'd obviously ask the Minister and Shadow Minister to respond to this, and then other panel members to have their input if they wish.
With our health system, my first priority is always patient safety, and it is just not safe to have particularly procedures that have a relatively low relatively low sort of turnover in a particular site to be spread over a vast, large number of sites. Clinicians, particularly with those highly specialised areas, need to have a very large turnover of those patient presentations. You can't offer every procedure everywhere, particularly in a sparsely populated state like South Australia. So the nature of medicine is changing. It is becoming necessary for us to centralise some services. Having said that, though, in particular critical areas, we always try to make sure that, particularly in regional South Australia, those particular areas, just birthing and so on, that they're available, and most especially primary health care is absolutely critical. That those areas are available in our regional centres. But I'm afraid some centralisation of particularly those highly specialised areas to certain centres of excellence is the way medicine's going, and to resist that I would be, I think, putting patient safety second to political considerations.
Thank you. Mr. Lucas.
Look, I did make some general comments about governance and centralisation earlier, but this question seems more specifically in relation to, I think, hospital service delivery in regional areas, I suspect. It was only 3 or 4 weeks ago on a cold and wintry Millicent evening in the southeast, you know the southeast, 500 people turned up to protest at a decision to remove obstetric services from the Millicent Hospital. And it's just one example of the fierce passion that regional communities have for the capacity to have ongoing delivery of services from their local hospitals. I do agree with Jack, it's impossible to have all services delivered at all locations, but I don't think anyone's arguing that. And certainly the people I meet in regional South Australia, my hometown's Mount Gambier, the people I meet, they accept that. Millicent has, for example, lost a whole series of services over a long period of time, but the straw that broke the camel's back for that community was when the decision was taken to remove obstetric services from that particular hospital. We saw not that long ago a concerted push by the government to close down a number of smaller regional hospitals, and there was a huge outcry from regional communities in relation to that. So there is a middle position. The government moved away from the closure of the smaller country hospitals as a result of that particular opposition, and it doesn't mean that regional communities are arguing for every service to be delivered at every hospital site, but there needs to be a balance, and I think what they want is a government and a minister that's prepared to look at ways of continuing to provide those services rather than hiding behind the rules and procedures as an excuse to cut every service that they can.
I'd invite other members of the panel to comment on this. I suspect Dr Rischbeith might have a view.
Look, I was involved with the RDSA and the AMA, the CWA, the National Farmers Federation about the community support for country hospitals. What we need in our health system is some generalists as well. We need to have not just an orthopaedic surgeon who operates on the right ankle. We need to have a system that has enough generalists in it so we can have general physicians and general surgeons being trained by the colleges, been trained in hospitals in the community. So you're going to have general practitioners who can put drips in patients in country hospitals, put chest drains in, look after a mental health problem, look after a range of conditions to a level that's appropriate for that person's training and the level that can be provided at their local institution. Then you involve the consultant services for extended care in the centres of, they're called centres of excellence. There's some very excellent centres outside the metropolitan areas. So let's get that right. We need to have some generalists in our training system. We need to have that in the consultant-led areas, and we need to have the support of those rural towns. Once you lose your maternity unit, you lose your theatres, you lose your anaesthetists, you lose your midwives, the generalists will leave as well. So once a town loses its maternity unit, that's it. Historically, it's happened all across rural Australia. So it's a sad day for Millicent. They need to be supported to make sure those other services don't leave. The challenge is going to be, how do we create the workforce where we train the generalists to provide services in country hospitals, and can we provide services where we've got general physicians and surgeons in some of our other larger hospitals in metropolitan and regional areas, to make sure that patients don't have to have the costs themselves to travel hundreds of kilometres just to have a hernia operation, which will potentially happen if we go down the super specialty route.
Thank you, Dr Rischbeith. Any other members of the panel wish to comment? Or
Look, there's just, from an urban perspective more than a rural perspective, there is movement with the beginnings of the Medicare locals and the new networks working together. And the conversations are starting to happen about primary care services going back outside the SA healthcare system and being managed in appropriate community-based service. I tend not to be as, I agree with the Minister and the Honourable Rob Lucas about having the numbers to do the work to keep the quality agenda up. But there is a surfacing reality in South Australia that we do have a new infrastructure to use as we go forward. So I tend to be more positive than that this will eventually move the services out of the hospitals and on back out to the community.
if there's no other comments, no, then we will go to the lucky dip again. Who would like to ask a question out on the floor?
Hi, I'm Harry Crawford. I'm actually a law student at Flinders, but I'm just interested in politics, so here I am.
Fantastic.
I know, it's strange to hear in this age group, perhaps. Anyway, tonight we haven't heard anything about the Aboriginal population, which is perhaps not surprising considering that the crowd here is pretty white and in a city. Nevertheless, given the gap between the health outcomes of Aboriginal populations and other populations, does either party have a particular action plan? And to what extent will that response require coordination between various departments, such as education and housing, and are the governments respectively aware of those challenges? And can either Mr Snelling or Mr Lucas say that at the end of the next election cycle, they can envisage a substantially better outcome in terms of health for the Aboriginal population?
Well, I was wondering where the health part came into it, but thank you very much, a very holistic and legal approach to it. I'll just ask then Minister Snelling and Mr Lucas to give a brief reply to each of those comments, specifically in regards to Aboriginal health outcomes.
I've just returned from the APY lands and seen the great work that Narnaba Health do on the lands, and SA Health has a big presence on the APY lands, dealing with the multifaceted issues facing with Aboriginal health on the lands. The government's just recently renewed its Closing the Gap funding, so a significant funding to go to trying to close the gap with health outcomes for Aboriginal and Indigenous and non-Indigenous Australians. It's something I've got a personal commitment to, but these are significant challenges. I'm not going to pretend that they're going to be able to be fixed overnight, but the government is making a significant investment towards closing the gap in partnership with the Commonwealth, and it's something we have a very strong commitment to.
All right, Mr Lucas.
Look, depending, I guess, on what happens this Saturday, certainly Tony Abbott has already spoken loudly and often in relation to this particular issue. As a former Minister for Health, he has a deep and personal commitment to the whole area of governance in Aboriginal areas, but also the issue of health outcomes. Certainly in the discussion, and I know Stephen Marshall has exactly the same commitment. I know there have been discussions between Stephen and our federal representatives, Tony Abbott and Peter Dutton. Clearly, if anything's to be achieved in relation to Aboriginal health, it's going to require cooperative effort between federal, state governments and the communities. And that's going to be the reality. In terms of your first question, which is, let me return to it, can we give a guarantee or a commitment? I can only give the guarantee that we'll work together with a federal government, whether it be Tony Abbott or Kevin Rudd, in terms of trying to get that cooperative effort to turn things around. But the reality has been it ain't going to happen in a short space of time. Anyone who says that they can turn it around in 4 years is deluding themselves and deluding everybody else. it's going to require sustained effort over a long period of time.
Dr Montanaro would also like to make a comment.
Look, it's a national travesty that our Indigenous population have, on average, a 20-year reduction in lifespan, and it's across the age groups. Yes, the answer is partnering. It's partnering with the Indigenous people and their communities, and it's taking the solutions to where the problem is. It is not an easy ask, but the traditional models that we currently have are not going to be the answer. So doctors are going to need to stand up and continue to hold the rest of society to helping with finding the solutions. The solutions are genetic, epigenetic, employment, education, health. It is, as I said, a national travesty, and I agree with your standing up and asking the question.
We're going to move on to a question that has been prepared prior to this talk by a panel of medical students from the AMSS. This question is, public hospital outpatient visits are considered valuable learning opportunities for medical students and junior doctors, but cost significant money for the state health budget. There have been recent moves by SA Health to try and shift more outpatient services into the private sector to reduce costs to the state, with subsequent loss of learning opportunities. How do you get the balance right between education and training and a ballooning health budget? I'd invite any of the panel members to start their response.
I wish I knew the answer. Look, significant challenges, and always in all these things there's always a balance. We are constantly searching with the constant increase in demand for health services. We're always looking for opportunities to make our health system work more efficiently. Outpatient reform is one of those, but what we're also committed to do, any reforms which we undertake, if they don't have significant clinical involvement in those reforms, they're just not going to get off the ground. And so with all of our reforms, as far as possible, we're trying to engage clinicians, doctors and nurses and other health professionals to get those reforms up. The outpatient reform, I certainly I certainly understand the concerns raised about the opportunities for training. I think we do need to make sure that we have, in any reform that we do, we don't compromise those opportunities.
Okay. Dr Plagakis, would you like to comment?
I think from 2 points of view, I guess from a public health point of view, outpatients are very inefficient, very time consuming in terms of space, in terms of waiting rooms. It's where patients get the angriest because they're waiting for us for hours because we get caught up with another patient. And it's a very difficult part of our clinical practice to manage, I think, on a day-to-day basis. But from a trainee point of view, it's invaluable, and the learning that we get from that clinic and planning for surgery or planning for an intervention or just checking up on a patient past discharge is a very important part of our practice. I agree that it's a very important part of our training, and I imagine that if we did move it all to the private sector, that would have to be accompanied by a move of registrars to the private sector to cope with that. And to also continue taking advantage of that. So as long as registrars move with the patients to the outpatients, I can see that would work in the private sector quite well. But I just wonder for medical students if that would potentially be a lost opportunity if they didn't follow us as well. There was a paper in the ANZ Journal of Surgery a couple of months ago looking at surgical education, and they found that out of all of the interactions that a medical student had with the surgical team, the interaction where the student was allowed to see a patient in clinic prior to any other doctor intervening, formulate a plan and then be able to present that patient to the doctor was the most valuable clinical experience they had. So that only occurs in an outpatients or in an emergency department, and we need to protect that or plan for changes as much as possible.
So Dr Plagakis suggesting some solutions there. Professor Beilby.
Look, there's two responses to the question. We actually have to make sure we teach in every available environment across the community. That's from private hospitals to publics to general practice to community health centres, where it is. So the bottom line is that the teaching centred around outpatients is a model that will need to change and evolve. We actually have to teach with other craft groups. It's not just medicine, it's nursing, it's allied health groups, because that's in fact the team-based care we have to go to. But I think the biggest thing for me is to make sure the culture of the healthcare system wants to teach and to educate. And my personal feeling that's drifted off the radar over the last 15 years. And I think it's coming back onto the radar, and that balance between research, teaching and service is what we have to make sure we retain in South Australia, because in essence that underpins the quality system we have at the moment. And I think that's an ongoing debate that we need to keep having over the next 5 or 10 years, particularly with the new reforms that the Minister and the government's leading at the moment.
Would any of you like to comment? Dr Montanaro.
I was actually going to say that I would like to see some transparency. Right from 2004, we've been told that there will need to be reforms in outpatients, and there have been numerous committees that have been convened with some clinical input, but I've yet to see any outcome of those committees, and I've been involved in those committees. The committees have been ceased without the reforms having occurred. Outpatient teaching is necessary, outpatients are necessary. However, I absolutely agree it does need to change. If you're going to have the change, you need a clinically driven change. We have a bureaucratic lack of transparency change. We still do not know what models of care, and the reason we don't know the models of care is the lack of transparency. We are going towards a new hospital in 2016. We have a virtual hospital with virtual models of care. It is past time to have the information out in the community so clinicians can help to ensure that the services will be present and working.
Dr Rischbeith.
One of the problems with our health system that all of us understand, having been part of it, is that we've got two funders. We've got the federal government, we've got the state government funding. So if you're doing teaching and training, one arm of government has one bucket of money for teaching, the other arm of government has another. And unfortunately, we haven't got someone who's taking responsibility for the whole teaching and training place. So if you're in private practice and you're teaching and training medical students, you're going to do that at an economic loss for those sessions. That's fine. If you can teach that person to be your replacement, then you've done a great job and the money doesn't really matter. However, if you're doing that all the time and your practice is running down and you're not being supported, then that's going to be very hard for you to continue that. So it's actually who is going to be responsible for the positions, work out where is going to be the best venues to do the teaching and training, and then who's going to fund them in a fair and equitable way. So the metropolitan hospitals have teaching budgets, the country hospitals don't have teaching budgets for students. So we need to have someone in our national space, the Australian government, say, we're going to be responsible for the health funding, and the same with education. We need to have that one funder responsibility, which unfortunately, until that happens, we're going to have these arguments at training places, education, who does it, who gets paid for it, and until that changes, it's going to be hard to really have some major steps forward.
Mr Lucas, any comments? No. Okay. We will go to the audience one more time. A couple of questions I can see on this right-hand side. All right, a bit of a fight over the microphone.
My name's Candice. I'm one of the 6-year medical students sitting with some of my more senior students in medical school. What we were just debating about is this issue of training positions after intern year. There's been much discussion about that tonight. There doesn't need to be any plan set in place to address that issue. I know, for instance, like there's 10 applicants for every one position in O&G training, and I think the list goes on and on the more competitive the specialty gets. I guess what's going to happen for us out here, myself and my friends? Are we going to be stuck as RMOs forever is my question.
I might ask Professor Beilby to comment on that. He indirectly addressed it earlier. I get a bit frustrated with this debate about the phrase tsunami of medical students. It's actually an extraordinary opportunity to have the workforce we need for the future, so it should be looked at in a more positive way to create the options as we move forward. I've just finished a national role where this debate is raging, and basically we're going to have to get an agreement between the states and the Commonwealth and the colleges to start developing some alternative pathways. Now, some of that's happening already. There's the STP program, the colleges are finding new innovations around training positions, but we actually have to we need a workforce plan. We need a national workforce plan with a state framework around it, so that we can actually start mapping out where the gaps in the service delivery, the gaps in the specialist models and the GPs or the specialist colleges are, and make a decision together. It's actually going to be political will that's going to happen, and the lesson we learned out of the intern crisis, if you have leadership with the jurisdictions being part of the solution, you can actually find a solution, as we did last year and will this year.
I think it's a major crisis, absolutely a major crisis, and I think there's going to have to be a political will across the Commonwealth and state jurisdictions to make it happen. The window that's opening up is Health Workforce Australia is about to establish a thing called MTAN, National Medicine Training Advisory Committee, I think, or network. I think David Swan may have the right term, I don't know. But that's about to be established, and I'm hoping we're going to end up with state-based workforce plans that link back to college training programs, and that's really the future.
Do you want to comment at all? Dr Plagakis.
I just wanted to ask, following on from that, is there any plan at present to expand the medical workforce? Is there any money to expand our medical workforce at a consultant level? Because some of the colleges have increased their training positions to meet with the increase of JMOs, but what's waiting at the end? Is there some hidden money pot somewhere?
No, there are no hidden money pots in health, I'm afraid to say. Look, these are something we need to work together with the Commonwealth and with the colleges to resolve. I certainly acknowledge it as an issue. We'll continue to do so. We're very committed to training and to making sure that we have enough graduates, or having those opportunities for graduates to become specialists. But it is something in which we need to do a bit more work.
Dr Montanaro.
The colleges need time to accredit positions. We've had a wholesale infrastructure change with in the metropolitan, the south, the north and the centre. We do not know what services will be available in which hospitals, so the colleges cannot accredit positions. So again, we are asking for an in-time awareness of what services will be where, so that we can assure trainees will be in a position where that position can count towards their specialty. We do need innovation. We need innovative models of how trainees can get their experience, perhaps a different form rather than a position, perhaps a logbook, so that you can have ensured that you have done the things and gotten the experience that you require for your exams. It is important to make sure that the workforce is where people need the services, so the old models of care will not be the models of the future.
Any other comments?
Yeah, I think it's important that we look at how we can use our current system better and use the trainers and the supervisors there. So there's going to be a challenge for all of you when you come out into the workforce. So how can we use our own skills better to train and teach you? But also I'd like to put a plea in for some quarantined training positions for the rural workforce, because currently we don't have that in our system, and until we have quarantine procedural, emergency and paediatric and psychiatric training places for those who want to be country GPs, we are going to struggle to replace our ageing rural workforce, aged approximately 57 on average.
All right. There's been a number of people putting up hands now, so we might make the most of that. So if anyone has any questions, they're growing. And it's up to you, it's a lucky dip from the audience to select who they want to get. There we go. Oh, that was quick.
Thank you. My name's Mike. I work for a company called Adelaide Unicare, which operates in the primary care setting. It's a question to both ministers tonight. With so much of the capital budget going to be absorbed in the new RA of the next 4 to 5 years, I fear that it follows that more and more of the recurrent funding is going to be soaked up by the acute care setting, and that's going to be to the detriment of primary and community-based care, and that runs contrary to what the government's trying to do. How do the governments think that they're going to, what plans will you put in place to prevent that from happening?
Okay, well, we might start with Minister Snelling.
Well, I mean, certainly this government, I think, would have invested more in primary health care than any government in South Australia before us. We have the GP Super Plus clinics. We have the enormous investment we have made in mental health, to building up our community-based subacute mental health sector as well. Now, I certainly agree with you, primary health care is going to be the way of the future. We are just not going to be able to provide all of the acute hospital beds, if demand is just allowed to continue to grow unchecked. and really what it comes down to is better management of people with chronic illnesses in the community so they don't end up in hospital. That is the key to meeting the challenges of an ageing population and in ever increasing demand for healthcare. But this government has made a significant investment in primary healthcare, and one of which I'm proud. There's always more to be done. Certainly agree with you. Agree with you on that. But I don't agree with you that it's something that we have let slip at the expense of the investment we've also made in our in the acute sector.
Mr. Lucas.
Thank you for the question, because I think I mistakenly referred to a review as the Monaghan review. It was the McCann review into primary health services. And look, I hear what Jack says, but certainly all those who speak to me indicate that as a result of that McCann review, a series of primary healthcare programs were defunded as of the 30th of June right across the board. And it appears that, I'm a relative new chum to this area of health, but it appears that there's this, I think Peter referred to this issue of federal and state overlapping or whatever in the training area, but certainly there appears to be the same debate in relation to primary health care, where the states seem to have this view, well, we don't need to provide this program because that's a federal government responsibility under some COAG agreement. From our viewpoint, the sense of primary health care in terms of keeping some people out of hospital, and for those who leave hospital being able to leave earlier and being looked after in their home makes good sense in relation to some of these particular programs. If we're there after March 2014, we'd look forward to working with the federal government again, because again there are crossovers and duplication in terms of responsibility in this particular area as much as the training area that Peter's talking about and others have talked about, and ultimately we're going to need to come to a cooperative arrangement with the federal government in this particular space.
Dr Montanaro.
We need the care that we need at the price that we can afford, and hospital care is very expensive care, so we need to keep hospital care for when we need hospital care. There is much care that we should be trying to avoid going to hospitals, and we would predominantly call that futile care. There are many conditions that should also be managed much better in the primary and secondary sector. For example, diabetes has 8 times the number of hospital admissions and many of those preventable than many other conditions. So we need to become very wise at what we're actually doing. Primary care is very inexpensive, with a GP visit being about $30 to $40. The average hospital admission would be $3,000 odd. When you have a hospital admission, you need to make sure health value follows that patient. I would describe it, and the AMA would describe it as the McCann report has made some cuts, and we would describe them as some unwise cuts to both primary and secondary care services. I think if we look to the rural setting, we see that primary care transitioning into secondary care is very wisely and sparsely done. There are models that will work. The model of let's cut everything other than acute hospital beds is not a way to keep health at 10% of GDP. Neither is it a way that we will be able to afford our health budget. We need to have innovation. We don't need to have cuts.
All right, we have time for 2 more questions tonight. We're going to take it to the floor once more. We're actually going to give this panel here the opportunity to ask a question. So if there's anyone in this group that would like to ask a question, that doesn't have to be, or there already is.
Hold on, let me just get it. Okay, hello, my name's Maya. I'm quite early on in my medical career, being only a second-year student, but there's been a lot of discussion and a lot of talk surrounding research and the opportunities that are available, especially with SAMRE being developed recently. And I'm just wondering what your comment is on staffing these research facilities with South Australian trained doctors, especially considering that it is one of the only medical fields which has not increased its numbers proportionally following the graduation numbers increasing, and as well probably on a clinical training level what we would expect to see if there's any changes towards research promotion as a medical pathway.
All right, so we've got some comments on clinical research and in particular the career pathways, but I'll take questions on either of those comments because I know there's a number of questions that have come in from the audience about what is the panel's view on promoting medical research. So with that in mind, would anyone like to comment?
That's a fantastic question. I think the state's actually beautifully poised to grow our research, medical research. The SAMRI, which has already been mentioned, has 3 universities involved, plus SA Health, in a partnership that's unique in the world. So we actually have 600 researchers, a couple of hundred of those will be ours, but in shared space. And for the first time we can see the research momentum coming back, and we've attracted 7 stars back to the state who are the new theme leaders who are outstanding researchers and all coming back to South Australia to work. The University of Adelaide's about to build an integrated clinical school with the vision is 3 medicine, nursing and dentistry in the same school and in some land that's just adjacent to SAMRI, right next to the NRA. And we are going to put a research clinical trials facility in that building. So for the first time, and I think University of South Australia, if there's anyone in the room, I'll play that other card, is also building itself a new research facility. I think it's the best place to be for medical research in the next 15 to 20 years, and in a career that will just explode with partnerships across the universities and SA healthcare system. I think we will create the best research centre in Australia potentially as we go forward.
Any other panel members like to comment on that? No, if there's not. All right, the feeling was that Professor Beilby's answered the question well. No, Dr Montanaro?
I might just raise a plea. I think there's, South Australia is well poised. I think the new biomedical hub is a very exciting opportunity, but there are also other centres of excellence around South Australia. The point I wanted to make was in the new Royal Adelaide Hospital and in that area we would like to see partitioned off areas for research, and we'd like to see some money partitioned off for research. It is very easy when you don't have budget bottom lines and budget lines to say, well, what can we cut, acute bed or research? We need to make sure that the money is available as well as the facilities.
Okay, which brings us to our final question for the evening, and we'll go to the audience once more. That gentleman has got his hand up. This better be a good question, sir. It's the one that's going to end the night.
I'm Nathan. I'm just a first-year student.
Oh, excellent. First-year student.
So my question is, there was a brief discussion on just more effective use of money to provide health outcomes, and there's been sort of a bit of further discussion just now. My question is, given that, is there going to be any emphasis or investment into sort of preventative measures or population measures to prevent people from having to go to see like a GP or having to take up a hospital bed in the first place? And do you have any examples of those?
Right. Who would like to answer that one? I know it's a passion of Professor Beilby, but Minister Snelling, you've got the microphone.
Thank you very much. Well, I mean, there is an enormous amount that we do in preventative medicine. We have a whole public health section as part of the Department of Health, which is really about keeping populations healthy and preventing the incidence of chronic disease. So certainly it's a big role that we play. I think the public debate gets very much caught up in hospitals and hospitals being in crisis and emergency departments and ramping, and not enough attention is given to preventative health measures. But certainly I think there needs to be greater public focus on preventative health and more public debate in that area. I agree with you entirely.
Right, Professor Beilby, this is your area of passion, I believe.
It's probably the number one question to shift the focus away from acute care and hospital care to prevention. Unfortunately, the financial side, the budget side of it, or the resources that go to that is very difficult to wrest away from the acute problems that the state has to deal with and the Commonwealth. I think that's one of the challenges for the system, to give enough resources and to give it long enough to make a difference. But the smoking campaign, the issues around diet and exercise, our obesity epidemic is going to actually tax us all for the next 20 years. I think it's a major question that I don't think has been answered particularly well, and it needs a significant influx of resources.
All right, Dr Montanaro.
The increasing health literacy in our community will certainly help, and doctors need to be at that forefront of continuing those messages. The messages need to start from people having a medical home, and that is one of the AMA's policies, and to make sure that when health resources are spent, that those health resources are spent wisely. So we do need primary, secondary and tertiary prevention, and as doctors we need to encourage each other to do better. We also need to set targets, but we need to be encouraged to meet those targets with some real dollars and some real funding, and we will rise to the challenge.
Dr Rischbeith.
One of the comments about preventative care, we haven't talked about the adolescent mental health problems, those who are aged 13 to 25. The effects of drug and alcohols on our younger population have been devastating. We've seen the self-harm, we've seen the overdose, we've seen the violence that have happened as a relation to Saturday night fever and Friday night fever, and this is costing our health system a huge amount of money. We as medical professionals should be actually promoting to our parents and our fellow members of the community about the risk of these problems, the effect this is having on our health dollar and the health effects on our children and our adolescents and teenagers. And until we can try and shift that focus away from marijuana and speed and alcohol, our health system is going to be more and more devastated by the effects of many of these illegal drugs. So that's one of the big challenges as far as preventative care, and GPs and our mental health services need to have that support to provide that emphasis.
Mr Lucas, as a former treasurer, does preventive health represent bang for buck?
Well, I think it does. So I think there's a good health argument for it. There's also a good treasury or finance argument for it. So you've got a happy coincidence of events there. So, I mean, I addressed some comments earlier in relation to primary health care and the concern I saw with the impact of the cuts as a result of the McCann review in South Australia, and I made the comments about the overlap or the duplication between federal and state responsibility, and clearly whoever's elected to the federal government position, whoever's elected to the state government after March 2014, there needs to be a cooperative arrangement between both levels in terms of primary health care, because it makes sense whichever way you look at it.
All right. Now I'm going to twist the questions somewhat to incorporate our final member of the panel. Dr Plagakis, you are a surgical trainee, however you're currently undertaking a Masters of Public Health. If we take that preventative public health viewpoint, how is it that you enthuse junior doctors and medical students to see the importance of public and preventative health? What made you see the light, so to speak?
I think for me, my main motivator has always been trying to improve efficiency in what we do, because in a hospital there is so much wasted time. You know, just that time you spend running here, there, and all these different interventions have come around, like EPAS and computers and Oasis that have just made things more efficient. I guess how it affects preventative medicine. There's a lot we can do in the community, and from a urology point of view, there's a huge focus on men's health, and thankfully that's increasing in the population, and people are being more educated on things that they can do and are more aware of seeking help when they need it. But often in the hospital system, there's just not enough time to incorporate that. So my interest in public health comes from improving efficiency, and I think that if we can improve our processes in the community, then that will translate very well to what we do in the hospital.
Wonderful. Well, that will conclude the question session of the panel. I'm very mindful of the fact that we have the opportunity of having both the Minister and the Shadow Minister here tonight, so I'm going to give them the final right of reply of tonight, and if there's one key message that they want to get out tonight from their particular party. I haven't actually let them know about this, so you're going to get it au naturel. So if there's any one key message that you'd like to communicate in regards to health to medical students, and the other distinguished guests that are here tonight, this is your opportunity.
Well, I think my key message to medical students would be this is a very exciting time to be a medical student, very exciting time to be going into medicine. With the challenges that we're faced with the investments that the government's making in infrastructure and in things such as EPAS, revitalisation of our country hospitals, revitalisation, effectively rebuilding of at least one of our metropolitan hospitals, and the new Royal Adelaide Hospital and the new way that will work. This will be a very, very exciting time to be in medicine. Certainly appreciate, and I guess on the somewhat less glamorous side as well, the advances that are being made and the work that needs to be done in community-based management of people with chronic illnesses and in preventative health. They are, I'd urge you as a student to really look at those areas. Don't get too sucked in by the sort of glamour of highly interventional, high acuity areas, because really in terms of outcomes for population health outcomes, it's really in the management of people with chronic illnesses in the community. It's preventative health, which is really where the future of medicine is going to be.
Thank you. Mr Lucas, your parting comment.
Now, let me shock you all and say I agree with the first part of what the Minister said 100%. It's an exciting time to be a medical student. Good luck and best wishes for your future studies and your future careers. The only point that I'd make in conclusion is that we've had the opportunity tonight to interact. You've had the opportunity to interact. Certainly, from my viewpoint, if you continue to have views that you want to put in relation to both your training or health policy direction, just go to my website and send me an email. I'd be happy to interact with you if you were a bit shy in terms of putting a point of view here tonight.
All right, the Minister is exercising his ministerial rights, and we'd just like to make one...
Just one more thing, and I'm not going to argue with anything Rob said, but just to extend an invitation to all of you who are medical students, if you do want an opportunity to have a look at what's happening at the New Royal Adelaide Hospital, I'm going to try and arrange that for an opportunity for medical students to actually have a tour, have a look at what's happening on that site. I was there this morning. It's incredibly exciting. We'll try and organise something perhaps through the Medical Students Society to provide an opportunity for students to come and have a look.
Fantastic. And I'd just like to ask you all to join me in thanking all the panel members tonight.
Okay, thank you all for attending. I hope you all enjoyed the evening. Join me once again in thanking both Minister Jack Snelling and Mr Rob Lucas for attending tonight. I'd also like to thank our esteemed panel guests, Professor Justin Beilby, Dr Sophie Plagakis, Dr Patricia Montanaro and Dr Peter Rischbeith for their insightful comments. And a big thank you to Dr Andrew Perry for his excellent moderation panel chair discussion. So thank you. We have a